Good afternoon, everyone, and welcome back to our final session of the 7th Annual Rocky Mountain Highlights in GI and Hepatology. Before we get started with this session, I do want to remind all of our attendees that if you were able to participate in the lunchtime interactions with our sponsors, please do not forget to enter yourself to win one of 10 $100 gift cards. You can go to the virtual exhibit hall link that Christy has pushed out into the chat. And remember to sign up for the raffle when you scroll down to the bottom of the page by entering your name and your email address. Again, as Dr. Whelan mentioned, this information will only be used to draw winners and will not be shared with anyone. So our final session is really to review kind of the latest updates in colorectal cancer prevention. And this session really is in honor of Dr. Dennis J. Anand, who his name is synonymous with colorectal cancer prevention. So we'll start off the session by talking about hereditary cancer syndromes. And my hope really is for this diverse audience to demystify what seemingly can be complex conditions that many of us don't necessarily see all that. I have no disclosures related to this talk. The objectives that I'd like to cover today is to really emphasize that each and every one of us, whether it's our primary care colleagues on the front line, our surgical specialists, or our gastroenterologists that perform direct access endoscopy or even clinical consultations, that really all of us have an incredible opportunity to help in the identification of these high-risk patients. And then I'll present a case that really highlights how important and helpful multidisciplinary management of these patients can be. So I'd like to start by presenting a case. This is a patient of mine. He presented to medical care at our GI division years ago as a 34-year-old male. He had a history of type 1 diabetes and had an insulin pump, and also had an appendectomy, and he was in the midst of finishing, believe it or not, his oncology pharmacy fellowship. He reported some hematochezia, and so he was referred for a direct access colonoscopy procedure. The endoscopist found this lesion in the patient's rectum, which may have been causing some of his intermittent hematochezia. And after careful inspection, as would be advised by Dr. Hazem Hamad, the patient had an endoscopic resection. Histology showed that the polyp was an adenoma, and it did have small foci of high-grade dysplasia. Accordingly, the patient was counseled to return in 3 months to re-examine this site of piecemeal polypectomy. As happens with many patients, he got busy with school, fellowship, life, and he came back 10 months later. Thankfully, the site of that prior polypectomy looked quite good. There was no evidence of residual or recurrent adenoma. But curiously, even though the patient had a full colonoscopy just 9 months ago, the patient had another polyp on the other side of his colon, not as large as the index polyp, but still above a centimeter. This polyp was removed en bloc. The patient was counseled to return for surveillance in 3 years. And as happens with many of our patients, he came back 6 years later. In the interim, he got married, he had 3 children, and actually came at the request of his wife because he was starting to notice some vague abdominal pain, and so she urged him to come for his surveillance procedure. Unfortunately, he at that time was diagnosed with an invasive adenocarcinoma, and as is done at all of our laboratories, had immunohistochemistry for Lynch syndrome screening and had absence of the MLH1 and PMS2 protein. He was referred to our Hereditary Cancer Center, where, of course, we learned about his personal history of cancer and prior precancerous polyps, but then also learned that his sister was recently diagnosed with endometrial cancer, and the patient very clearly volunteered that his father had colon cancer in his 30s, and his grandfather had colon cancer in his 20s. He underwent germline genetic testing, and it is no surprise that he was found to have a pathogenic variant in the MLH1 gene, consistent with Lynch syndrome. Lynch syndrome accounts for up to 5% of all colorectal cancers. It's actually quite common, with a prevalence of up to 1 in 226 patients. So in fact, this is more common than the BRCA1 and 2 mutations that gets so much more attention in the medical community and in the broader community. It's caused by an autosomal dominant inheritance of a mutation in one of 4 mismatch repair genes, or the EpCAM gene, which lives just upstream of MSH2. The hallmark is that it causes microsatellite instability in these tumors and clinically manifests as multiplicity of cancers that occur often at much younger ages than we would expect in the general population. We know that the cancer risks associated with Lynch are significantly increased when compared to the general population. Colorectal cancer risk can live at about 60% over an individual's lifetime. And you can see the series of other cancers that are associated with Lynch syndrome and the risk over lifetime compared to the general population. Thankfully, when these patients are identified, we have excellent opportunities for intervention and risk reduction. Even before the patient meets a gastroenterologist, we have the ability to really prevent cancers in these patients. These are results from the CAP2 study published by John Byrne in 2011 that showed that patients who were able to take aspirin every day for 2 years, their risk of colorectal cancer was reduced by 50% at 5 years. So a slightly delayed benefit, but substantial. The 20-year follow-up results were just published and are in fact still in press and show that this protective benefit persists at long-term follow-up. We know that hysterectomy for patients who are identified to have Lynch syndrome, of course, eliminates the cancer of the risk of uterine cancer. And as gastroenterologists, we are all familiar with the protective effect of colonoscopy and polypectomy in both reduction of colorectal cancer incidence as well as colorectal cancer mortality. For patients diagnosed with colorectal cancer who have Lynch syndrome, we know that their risk of developing a second cancer is quite elevated. And therefore, we customize surgical approach by offering a more extended colectomy for these patients. For those that are diagnosed with more distant disease, we're also familiar with immunotherapy and the promising response rates that we're seeing in patients who have microsatellite unstable tumors. We, of course, take care of the patient who's right in front of us, but these hereditary syndromes are familial by nature. And we have this really awesome opportunity to not only treat our patient, but systematically identify all potential mutation carriers within the family, perform germline genetic testing to identify whether they've inherited the same germline mutation. And essentially, we have this opportunity to implement cancer risk reduction strategies, not just for our patient, but in fact, all of their family members who are affected. And at times we can do this before these individuals even develop cancer. So how do we identify these Lynch syndrome patients? Well, the National Comprehensive Cancer Network is an outstanding resource which really updates its risk assessment guidelines on an annual basis and incorporates new evidence as it comes in. Unfortunately, these algorithms are complicated. Even for somebody immersed in the field, these various branching points and long lists of criteria are very, very difficult to always remember. Our GI societies similarly have put out very helpful risk assessment criteria, but again, they're very complicated and are very difficult to keep on the tip of our fingers when we're doing direct access endoscopy, or for our primary care colleagues who are meeting their patients and ascertaining personal and family history of cancer. So it's no surprise that even though these patients get excellent care at our institutions and multiple providers are communicating with one another for the complex management of these patients, that at times the hereditary risk assessment is overlooked and there's this diffusion of responsibility, assuming that another specialist is taking care of the risk assessment. So it's no surprise that Lynch syndrome in our country is grossly under-recognized. I am optimistic that we're doing a little bit better than this when the study was published back in 2011, but still there are estimates that less than 10% of Lynch syndrome mutation carriers are even aware of their diagnosis in the US. So I like to distill down really some very simple red flags that, putting all the detailed criteria and lists and guidelines aside, that if you notice one of these red flags, should prompt at least a gut check, or at least a phone a friend, and that friend can be me. Any patient that you encounter who's had advanced neoplasia at a young age. And you can see that I note advanced neoplasia, not just cancer. And so these are also applicable to our patients who present for direct access colonoscopy or upper endoscopy and are found to have a cancer or even a precancerous polyp at a much younger age than we would expect. Certainly any patient who's had multiple neoplasia, so either polyps at the same time, polyps separated in time that seem to be fairly advanced, or cancers, multiple cancers within the same individual. And then of course, we always think about family history, particularly if there's similar types of cancers on one side of the family, especially if any of those cancers are occurring at younger ages than we would expect. I would caution though that just because a patient doesn't have a family history, it doesn't exclude a hereditary syndrome. And that's for a variety of different reasons. Certainly even in our very high risk genetic conditions, if patients even at most have an 80% lifetime risk of getting colorectal cancer, a 60% lifetime risk of getting endometrial cancer, that means that 2 to 4 out of 10 patients with a genetic condition may never develop cancer. And that's not to say even our lower penetrance or lower risk genes that we think about, MSH6 and PMS2, where in fact the majority of patients may not develop a cancer over their lifetime. And so the incomplete penetrance is partially why we think about family history with a grain of salt. And so families can in fact look like this, where there are multiple unaffected carriers who can still pass the disease along and may still develop a cancer, even if it's not been diagnosed yet. And that's not to mention what we know about the difficulties with regards to collection and action on family history. Oftentimes, we just can't get a complete family history. Patients don't know it. We're seeing increasingly smaller and smaller nuclear families. And then, of course, mutations have to start somewhere. So there can be de novo mutations. So with that said, if you can keep in mind these simple red flags, these are really things that should at least make you pause in your clinical practice, perhaps put an asterisk on the patient's chart to send that patient to someone who can do a more detailed multi-generation cancer family history and risk assessment. So when we think about our patient, there were multiple opportunities where perhaps his course could have been different. Certainly when he moved to Colorado and established care with his primary care doctor, his endocrinologist for his type 1 diabetes, this patient was well aware of his family history when he was operated on for his appendectomy. But I really want to emphasize this moment that the gastroenterologist had in the care of this patient, where he really declared himself with multiple neoplasia, young patient, 2 large polyps in different parts of the colon, and really with a few simple questions would have volunteered his family history. And if these red flags perhaps were recognized at that time, we all think about the cancer that maybe would have been avoided if he was entered into a rigorous Lynch syndrome screening program. But also his life planning. He got married, he had 3 kids, and we potentially had the opportunity to offer his family pre-implantation genetic counseling and genetic testing. And then of course, his sister's endometrial cancer, which occurred between the time that he had his colonoscopies and when he presented for his cancer, and her cancer perhaps could have been prevented as well. So clearly there are multiple opportunities that we can all recognize in improving identification of these patients. I'd like to shift gears and talk about at times how complex these patients can be and how important it is and helpful it is to have a multidisciplinary approach to managing these folks. So I'll start again with another case. This is a patient that actually was referred to our surgical center, our colorectal surgeons, 56-year-old woman from Cortez, Colorado. She has a history of diabetes that was insulin dependent, coronary disease, high blood pressure, chronic smoker with a several liter oxygen requirement for her COPD, chronic kidney disease, and yes, Amanda, she had NAFLD, though I think that was the least of her problems. She actually underwent her first screening colonoscopy at 56 and was found to have hundreds of polyps. These were sampled and all of them were tubular adenomas. So she was referred to our surgical group because she had germline genetic testing, which confirmed a pathogenic variant in the APC gene, condition that causes familial adenomatous polyposis. And as we all learned in medical school, FAP is associated with a 100% lifetime risk of colon cancer. Therefore, the treatment of choice is colectomy, right? Well, our surgeons actually paused on that referral and sent her to our clinic for further evaluation. And as we met her, we learned that she has no other personal history of cancer or precancer. She did state that she had a few extra teeth that were extracted when she was a child. She says that she has these subcutaneous growths, but we're told that they were benign. And then also notes that she has these lesions or bumps on her skull. In looking at her family history, she reports that her mom had colon cancer at the age of 67 and passed away at 69. She has an aunt who also had colon cancer in her 40s, though is still living after colectomy. This aunt had a lot of polyps, and then her grandfather had a colostomy bag and presumed colon cancer as well. But as we learn about her family history, it's interesting to note that her mother didn't die of her colon cancer. She actually died of wound healing complications after her surgery. So what do we know about this gene mutation? Well, what's interesting is that the APC gene is a very, very large gene, and we've identified very unique genotype-phenotype correlations, meaning the location of the mutation on the gene can be associated with clinical manifestations. And so for this woman who had a mutation on the 3' end of the gene, this location is associated with an attenuated phenotype, so a more mild phenotype of colon polyps and desmoid tumors. So sure enough, when we performed a repeat colonoscopy on this individual, this is a representative image, she certainly has many polyps, but they're all tiny, and there's large areas of intervening normal mucosa. And as you can see on her rectal retroflexion image, her rectum appears to be completely spared. There's no polyps in sight. We performed cross-sectional imaging, which showed, though it was asymptomatic, a subcutaneous lesion in her right paraspinous region, consistent with a desmoid, and performed an upper endoscopy, which had not been done yet. And you can see that she has really remarkable and substantial duodenal polyp burden, including involvement of her ampulla. So in summary, 56-year-old woman with FAP, confirmed by genetic testing. She has multiple medical comorbidities. In fact, has an attenuated or mild colonic adenoma phenotype with rectal sparing, though she has significant duodenal polyp burden, including the ampulla, and she also has desmoids. So what do we know about desmoids? Desmoids are potentially catastrophic in these patients. They're infiltrative, multifocal. They can have a significant impact on morbidity and mortality due to compressive effects, and they are the leading cause of mortality after colectomy in FAP patients. And you can see images from patients of mine, and one of the patients there in the center of the slide had really a significant desmoid in his back that really grew out of control, and this patient unfortunately passed away. But you can imagine that intra-abdominal desmoids can wreak havoc after a colectomy if they're this aggressive and infiltrative. So how do we assess patients for risk of desmoid complications? Well, this was a risk stratification system published out of Cleveland Clinic. And if we think about our patient, we know that gender portends high risk. Patients with multiple extracolonic manifestations are at increased risk. Those who have a family history of desmoid complications, and then the location of the gene. And so this really squarely puts our patient in that very high risk category. So for patients that are in high risk for desmoid complications, we really try to delay surgery as much as we can. If surgery needs to be performed, and really we'll talk about the indications for surgery in FAP, but if the patient has a cancer and really needs a surgery, we try to perform an ileorectal anastomosis because ileorectal compared to a pouch is associated with a lower risk of desmoid complications. Of course, this can only be performed if the rectal polyp burden allows. So when we think about the timing and the options for different types of colectomy in FAP, certainly the strongest indication for colectomy is a patient who has cancer or multifocal high-grade dysplastic lesions where we worry about progression to cancer. We have to balance this with the patient's perioperative desmoid risk, and in particular for our patient, just her overall operative risk. And if we can get away with it, if the patient has a relatively spared rectum, we try to offer an ileorectal anastomosis. So what did we do for our patient? Well, we actually ended up deferring colectomy and dealing with her duodenal polyp burden. We relied on our therapeutic endoscopy colleagues. I believe Dr. Edmundowitz did a few of her procedures where she had ambulectomy and serial endoscopic mucosal resection of her large duodenal polyps. For now, I'm just observing her colon. If we ever get to a point where all those tiny little polyps are starting to convalesce, or histologically we're starting to see any high-grade dysplasia, we'll have to have a repeat discussion about the risks and benefits of colectomy in this woman. So to conclude, everyone, whether you work in direct access endoscopy or in primary care or in the clinics, can play a critical role in identifying patients, just keeping in mind simple red flags. Any advanced neoplasia in a young patient should raise your eyebrow. And this is very important because if we identify these patients, we have really amazing opportunities to reduce the burden of cancer, not just for our patient, but for their family members. And then for sometimes these complex patients, even though the board question is pretty easy, multidisciplinary management is critical to really avoid complications. And although Raj didn't say so directly, oftentimes in GI we talk about not poking the pancreas, but for me, I'm very, very cautious and really try to avoid poking the desmoid. So I thank you so much for your time.